How is everything?
Everybody can hear us, or do you want to check your presentation? You can talk with the host. Host is here, so you can ask them to any technical support. They will help you. The host is here.
Good. Dr. Reena, do you want to check your presentation?
Let me open my presentation.
Yes.
Good evening, Shah sir. Are you there?
Assalamu alaikum. Hello, ma'am. Professor Vishali.
Hello.
Ma'am, how are you?
I'm good.
Thank you for coming.
You're very welcome. Thank you for the invitation.
Yes, thank you. Thank you, ma'am. You came Bangladesh, I think, Professor Vishali, Professor?
Yes, yes.
Yes, I think in the Bangladesh Academy of Ophthalmology conference, you came.
I know. I've never been to Bangladesh. I think I had to come, but something happened at the last moment and I did not.
Okay, okay. Ma'am, here Dr. Rajiv Hussain, he will conduct the session. And
Okay.
here is Dr. Jasmine Ahmed. She's the associate professor of very renowned institution and Chittagong Eye Infirmary and Training Complex. And you know, the president of Ophthalmological Society of Bangladesh will join with us
Okay.
very soon.
Still, we have to wait some more to join.
Yes.
See. কয়জন জয়েন করছে এটা কি দেখা যাচ্ছে ডক্টর নোমান?
না, আমার কাছে দেখা যাবে না। অলরেডি প্রায় 40 এর মতো পার্টিসিপেন্টস জয়েন করছে, বাট আমি একটু দেখছি।
ডিস্ট্রিবিউশনে হোস্ট কে আছে একটু দেখেন তো কে কে জয়েন করছে স্পিকাররা। আসিফ তুমি কি আছো?
জি স্যার।
দেখো তো কে কে জয়েন করছে স্পিকার প্যানেলিস্ট।
10 স্যার।
10 তো আমি দেখতেছি, মানে
এখানে কে কে আছে? ইজ देयर you know
স্পিকার প্যানেলিস্ট এন্ড আদার ওরা জয়েন করছে কিনা একটু দেখো খালি।
ঠিক আছে, আমি আরেকবার সেন্ড করতেছি।
Professor Hussain has joined, I think, already.
Hey.
জয়েন করছে না প্রফেসর টিশালি, প্রফেসর হুসাইন।
পাচ্ছি না। আসিফ সাহেব, are you there? আসিফ সাহেব, কতজন জয়েন করেছে? হ্যাঁ, ডিএল শাহ তো স্যারকে দেখা যাচ্ছে।
Sir, I have already sent a mail to all the panelists, so I think they will join shortly.
Yes, no problem. So এখনো পর্যন্ত কতজন জয়েন করেছে? আমি এখান থেকে দেখতে পাচ্ছি। প্রফেসর হুসেন, হ্যাঁ?
7%.
7, বাট আমি দেখছি না কিন্তু। আমি আপনি একটু গ্যালারি ভিউ।
Can you click on the participant sir? Can you click on the participant below sir, question and answer? Participants sir.
Participants is 32.
Sir, click on the participants, then you will show a list at the left.
No, আমার participants দরকার নেই, আপনি আমার প্যানেলিস্ট দরকার। প্যানেলিস্ট আর হোস্ট স্পিকারসদের দরকার।
Okay sir.
Hello Professor Hussain. Hello sir, Professor Devnarayan Shah sir.
Hi.
Hi, how are you? Dr. Rajiv is waiting for you. Dr. Rajiv is waiting for you.
Oh,
Namaste, sir.
hi Dr. Rajiv.
Yes sir, thank you sir. How are you sir? How are you? Good evening everyone.
Hello Professor Hussain. I have just talked to Professor Nadim about Sir Glaucoma, Sir Academy of Ophthalmology webinar will be start from next month, and different subspecialty glaucoma, cataract, and so Professor Nadim Hafiz Bhatt is the responsible for the glaucoma session. I just talked to him.
That's nice. So how are you, Rajat?
Yeah, thank you very much. Thank you very much.
Dave?
Yeah, it's great to see you all.
Thank you.
I think Dr. Ranju is joining. She is connecting. I think our rest of the participant is still, we have a time around 5 minutes.
Yeah.
So we can wait a
Yeah.
few more minutes to join other. Dr. Numan, আপনি কি ট্রাই করছেন সবাইকে একবার নক করছিলেন? Did you know?
How many participants are there altogether, Dr. Rajiv?
Sir, we have around 9, 12, 14, sir. 14 will be in the these things and the webinar participant, and rest of the participant will join. We have unlimited option.
Okay.
Actually, sir, in our webinar, almost 5,000 viewers are very common in the YouTube, Facebook, and different other groups. So yes, it's a very usually around 5,000, and usually in presence participant usually 50 or 70 direct. They just directly they can enjoy. And most of our people from Bangladesh, they used to enjoy through the Facebook Live.
Yes.
Sir.
Yes.
That's good. Yeah, Dr. Vishali is also awaited.
Sure. Hello, Dr. Shah.
Dr. Vishali,
How are you?
I'm fine. How are you?
I'm good.
Uh-huh.
How are things in Nepal?
Well, COVID is increasing like anything since last about 2 weeks.
And is it a mild disease?
Majority, of course, is mild, with mild manifestations. But yes, there are cases who have gone into complications, few casualties.
It's like India. We are having the same issue.
Yeah. And today in hospital, altogether we have 64 cases admitted COVID.
Assalamualaikum. Welcome to you all. Rajiv, Vishali, Hossein Ahmed, yeah, welcome. Parthupati Majumdar, Parthupati Dotto, yeah, and other are already. Today in Pakistan, you told that about 64 deaths. In Bangladesh, it was 26.
For starting Zoom meeting.
The last 20. Jasmine, yes, welcome.
Open Zoom meeting. এটাতে চাপ দিলে তো ঢুকে যাওয়ার কথা।
দেবনারায়ণ শাহ।
কি আসতেছে?
Any problem? Hey, yeah. Noman, mute yourself. Noman, mute yourself. Yes. Okay, Rajiv. Now it is okay.
Yes, sir. Yes, everything is okay.
Yeah, fine. Professor Dr. Debnarayan Shah. Welcome.
Hi, thank you.
Yeah.
Welcome to Professor Sarfuddin as well.
Yes, thank you. During last month, some of the webinar, Parthopratim Tattva was with us, and also Vishali Gupta was also with us. in some of the webinar, isn't it? Women's in ophthalmology, probably you were there. Jasmine? Okay.
It's almost 8. We can wait some more minutes, I think.
Yes.
Still need to join some of them.
It is 8. We can wait for 5 minutes.
Okay.
We can wait for 5 minutes and then
Yeah.
we'll start.
Yeah.
পান্নু ভাই ঢুকতে পারছে না।
Pakistan, it is 9 p.m. In India, it is 7:30, isn't it?
Yes, India is 7:30.
Yeah.
Dr. Chessman, you have 2 IDs open. Can you please stop your 1 ID?
Yes, Jasmine, you have 2. You should
You have
stop
2
1.
IDs open, please.
I think hang করে গেছে।
Hello, Asif Shahab?
স্যার শুনতে পাচ্ছি স্যার।
হ্যাঁ, ডক্টর পান্নু ঢুকতে পারছে না, আমাকে একটু
স্যার
help
আমি
করছেন?
কথা বলতেছি, স্যারের সাথে আমি কথা বলতেছি স্যার।
হ্যাঁ হ্যাঁ। Where is
Niaz
Ranju?
Rahman, did you contact with Niaz Rahman?
Yes, yes.
Okay. In one of the meeting, I met Dr. Dev Naran Shah, probably in Shantiniketan, isn't it? In probably in Aquan. Can you remember? Yes, there was a meeting in Shantiniketan.
Which year was this? Roughly?
Probably 16th or 17th.
2016.
Yes.
Sir.
Can you remember? In Aquan conference, Aquan conference.
Yes, sir.
I think my name was there.
Oh yeah.
Dr. Niaz
Somehow I missed that.
Oh, okay, okay.
Yeah, I was at that time out of country.
Oh, yeah.
Joined that. Dr. Shamanta, he
yes,
was
Shamanta,
with me.
Yeah.
Dr. Ranju is there? Ranju Kayal?
Yeah.
Dr. Ranju?
Yeah.
Hi.
Yeah.
There she comes.
Namaste, sir. Namaste.
Namaste. How are you, Ranju?
I'm fine, sir. How are you doing?
Fine.
Ranju, nice to see you after a long time, huh?
Yeah, Rajiv, nice to see you. How are you?
Thank you. Yeah, I'm fine.
Partho.
Hello. Hi. Dr. John?
Any other new?
Dr. Dawn Lim, she's the department in charge of National University Hospital, Singapore.
Oh, hi.
Yeah.
Hi. How are you?
Hi, Dawn.
Thank you for the invitation.
Yeah,
Don Lim. Okay, welcome.
Professor Vishali is here. Professor Dr. Dev Naran Shah is here. Professor Partho Pratim Datta is here.
Dr. Rina.
Dr. Rina is here also. Professor Sharfuddin, she is the president of Bangladesh Ophthalmological Society. I think everybody has come except.
Yeah.
Hi, Vishali ma'am. Good evening.
Yeah.
Good evening, Partho. How are you?
Pannu bhai, Dr. Jahidur Rahim. I think we are all set except Dr. Niaz. He's also coming. He's just he's taking time to join, and
some technical issues. Maybe we can wait another 1 or 2 minutes.
1 or 2 minutes. Just I'm calling.
And Dr. Masood need to join.
Dr. Niaz is busy practitioner. I hope he got free from his.
But COVID has made us not the busy, lazy. Yes, Niaz Ahmed with us. Welcome.
Hello.
Assalamualaikum.
Assalamu alaikum.
Nice to see you. Hi, Dr. Shah. How are you?
I'm fine. How are you, Niaz?
Great, great. Vishali. Good to see you, Vishali. How are you
Hello,
doing?
hello, Dr. Niaz. I'm very good. How are you?
Great, great, great. Fine.
Good to see you.
Same here after a long time.
Rina is also with us.
Hi.
Dr.
Hello.
Manju.
Rajiv, I can see
Alaikum.
Rajiv.
Yes, sir. Yes.
Alaikum, sir.
Pannu, Jahidur Rahman Pannu is with us. Where is Masood?
He's coming. Just 1 minute.
Okay, okay,
Just-
okay, fine.
We will.
Partho, how are you?
Yeah, I'm fine, sir.
You're doing okay?
What about you, sir? Fine.
I'm also doing all right. Have you, all of you have got back to work? Working?
Yes, sir.
Yes. We have also started. I'm doing like 60%, 60, 70%, not 100, but for 4 days I work full 4 days.
And we are talking that
Dr.
COVID has
Masood,
made us lazy, not the busy. Because we have culled
Manju,
down to 40,
you unmute
50 or
yourself.
60%.
I think
You have two
1, 2,
IDs
3,
open,
4, 5,
Manju.
4, 5, 6, 7, 8, 9, 10.
Yeah. As if I try to close one, it makes me close both. I don't know.
Okay.
This is the link.
Okay. Go on with this because we will start now. I think we have already joined everybody, and
Yes.
thank you. So, what is our
Dr.
planning?
Brown.
Actually, I want to just give you one plan that we will start now. And after introduction, the program will be conducted by Dr. Rajiv. And after introduction of all panelists and speakers, we will start the session. Each speakers will get that 10 minutes time. And after 10 minutes, there will be some panel discussion about that topics. And then again, so the speakers will get the 10 minutes. And I'm requesting everybody to take care of that timing. And I'm request আসিফ সাহেব আপনি ফেসবুক লাইভ শুরু করেন আমরা প্রোগ্রাম শুরু করতে যাচ্ছি ঠিক আছে আপনি আমার পেজে এটা শেয়ার করে দিবেন হ্যাঁ
Yes, sir.
আর আই এম ডক্টর আসিফ at 9 minutes তুমি আগের মতো অ্যালার্ম দিও ঠিক আছে ডক্টর
Yeah, we
আসিফ
can start now. Dr. Numan, we can start
Yes.
now. So we are going to start.
So welcome to this session and honorable respected guest and panelist. I'm Dr. Shams Mahmoud is starting the program. Here we have very renowned speakers from different countries, total 6 countries. We have a great get together and different panelists from different countries. Welcome to this session. And as a Secretary General of the Ophthalmological Society of Bangladesh, Chittagong, I am just requesting Dr. Masood Parvez to start the program with a very with his speech, and then Professor Sharfuddin sir will tell something as a guest of honor. Then Dr. Rajiv will introduce everybody and start the session. Please, Dr. Masood Parvez. Dr. Masood Parvez. Hello, Dr. Masood Parvez. Are you there?
Yes.
Dr. Masood Parvez, please.
Hello.
Hello.
We can hear you.
Masood, you start. Yes,
sure.
you start.
Yes, we can hear you.
You give your welcome speech.
Dr. Masood Parvez, please tell something because the program is started.
As a part of our academic activities from OSB Chittagong, we have arranged several webinars. This is the latest one. I welcome you all in this session. I wish this session will help us, especially our students who are going to face masters and fellowship exam. They will get the benefit out of it. I wish this webinar a great success. We have many of international heavyweight speakers. I wish our students gets maximum out of it. Thank you very much. Dr. Rajiv, I invite you to start the session, please.
Thank you, Dr. Masood. I like to welcome everyone to today's webinar. Our webinar today will be Fight Against Fire. This is the very burning issue about uveitis. So we are delighted to have all our distinguished guests, special guests, and learned panelists and speakers. We welcome you all from Chittagong OSB branch. So I'd like to introduce everybody today. Today, our chairman of the session is Dr. Masood Parvez. He is associate professor and departmental head of Chittagong Medical College and president OSB Chittagong branch. And our guest of honor is
Dr. Rajiv,
Professor.
can you please share your slide?
This one. Just a minute.
Thank you.
Yeah, can see everyone. Yeah,
yes,
sorry.
Everything is visible and audible.
Okay, now this is his portfolio. So I'm going to our guest of honor is Professor Mohammad Sharfuddin Ahmed. He is professor and chairman of Department of Community Ophthalmology under BSMEU, President Ophthalmology Society of Bangladesh, President Bangladesh Community Ophthalmology Society, President Oculoplasty Society of Bangladesh, past Secretary General Bangladesh Medical Association, and President Bangladesh Ophthalmic Research Forum. Welcome you, sir. Our special guest of the today's session, Professor Deb Narayan Shah, is the current Vice Chancellor of National Academy of Medical Sciences, NAMS, Bir Hospital, Kathmandu. Past Head of the Department of Ophthalmology, Tribhuvan University Institute of Medicine, Kathmandu. Past Executive Director, BP Corella Lance Center for Ophthalmic Studies, Tribhuvan University, Kathmandu. Past member of National Development Council, Government of Nepal. Past President of Ophthalmological Society, Nepal. Welcome you, sir, too. And I'm Dr. Rajiv Hussain. Today I'm conduct as a moderator. I am working as a CITC as a senior consultant and departmental head of cataract service and the organizing society secretary of OSB Chittagong branch. And the Professor Dr. Vaishali Gupta, the Vitreoretina and EVA expert, Postgraduate Institute of Medical Education and Research, Chandigarh, India, President, Uveitis Society of India, Chair, Scientific Committee, Vitreoretinal Society of India, Secretary General of International Uveitis Study Group, Member, American Academy of Ophthalmology, Club Jules and Gognin, and the Macula Society. Welcome you, ma'am. And next panelist is Dr. Dao Lim, the consultant ophthalmologist and departmental head of Uveitis Service, Ophthalmology Department, National University Hospital, Singapore, as an assistant professor, Yong Lu Lin Medical School, National University of Singapore. Welcome you too, ma'am. Next panelist is Dr. Jasmine Ahmed. She is Associate Professor, Institute of Community Ophthalmology, Chittagong, Bangladesh. Welcome you too, ma'am. And panelist is Dr. Niaz Abdul Rahman, Consultant Vitreoretina Surgeon and Managing Director of Bangladesh Eye Hospital, Director Retina Foundation and Eye Center. Welcome you, sir. Our next panelist is Professor Hussain Mohammad Khakon, Professor, Department of Ophthalmology, Lahore General Hospital, Amiruddin Medical College, Postgraduate Medical Institute, Lahore, Pakistan, consultant ophthalmologist and retina surgeon, Shukat Khanum Memorial Cancer Hospital and Research Center, Lahore, Pakistan. Welcome you, sir. Sorry for the pronunciation. And next speaker is Dr. Parthopratim Datta Majumdar, is Senior Consultant, Department of Uvea Intraocular Inflammation, Shankar Naturala, India, founder cum Chief Editor of Popular Ophthalmology Portal, www.eopatho.com. It's very famous site. And next speaker is Dr. Rina La Disti Nora, lecturer and medical staff, Universitia Indonesia in Kipto, Mangunkusumo, Kirana Hospital and Universities Indonesia Hospital, Scientific Coordinator, Indonesia Ocular Inflammation and Immunology Society. Welcome you, ma'am. And Dr. Ranju Koral, Assistant Professor and Uveitis Specialist, BP Koral Alliance Center for Ophthalmic Study and Institute of Medicine, Nepal. Welcome you, Ranju. Dr. Jahidur Rahman Pannu, he is our next speaker, consultant uveitis and ocular immunology, head and consultant of the Department of Uveitis and Ocular Immunology, Bangladesh Eye Hospital. Welcome you, Dr. Jahidur Rahman Pannu. Our next speaker is host and speaker, is the main key person of this, behind this show, Dr. Shams Mohammad Numan, is my fellow colleague, senior consultant and head of glaucoma, and Chittagong Eye, she is working at Chittagong Eye Infirmary and Training Complex, member secretary of Bangladesh Ophthalmic Research Forum, general secretary, OSB Chittagong, council member of South Academy of Ophthalmology. Welcome you all to today's session. So I like to invite our first speaker, sharing them. First speaker will be today's our Dr. Parthopratim Datta Majumdar. He'll be talking about the mistakes and one should not do while teaching a case of uveitis. Dr. Parthopratim, you can start your presentation. Welcome you.
Good evening.
Technical team, please support him.
I think my slides are visible, right?
Yes.
Yeah, yet to come. Yeah.
So good evening, everyone. So I'll be talking on 10 mistakes to avoid while treating a case of uveitis. These are basically 10 case scenario I'll be discussing. So to begin with, a 43-year-old lady presented with blurring of vision and mild ocular pain. She was diagnosed elsewhere as a case of iridocyclitis. She was started on topical steroid and cycloplegic and was being managed as anterior uveitis. She was investigated extensively elsewhere. All laboratory parameters were normal. When I dilated the eye and examined the patient, this was the fundus picture. You can see the confluent areas of retinitis in the periphery. So it was a case of acute retinal necrosis. So the first mistake one should not do is don't forget to examine the fundus in uveitis patients. This is the most important. The second scenario, a little different, but on similar note, a 22-year-old male presented with diminution of vision, subsequently diagnosed as a uveitis. You can see here the referred doctor wrote anterior chamber cells, flare and KPs, and extensively investigated, started on oral steroid, and when vitreitis of the patient did not respond to treatment, he was planned for oral methotrexate and sent to us. This patient, when I examined, I could see the stellate KPs here in the corneal endothelium, but the game changer was when I asked the patient to come next day and examine the patient in non-dilated pupil. I could easily make out the loss of iris pattern here, as you can see here. So it was a case of fuchs uveitis. So examination in non-dilated pupil is very important. Sometimes you can miss the iris nodule if the pupil is dilated. The second is the fuchs uveitis, where you have to examine the collarete, the examining part near the collarete, where there can be the blurring of iris crypts. So one can miss if you are examining the patient in dilated state. Also in NBI, which starts as a bud like this from the pupillary margin, you can miss these findings if you are examining the patient in a dilated pupil. So always make sure you are examining the patient in non-dilated pupil also. So number 3 is again another case scenario. A 28-year-old male, known patient of HLA-B27 associated uveitis, presented with history of ocular pain in the right eye, and the patient typically complained that his pain increases while reading and writing. The right eye, there was no congestion, AC was quiet, and he was reassured and advised nil intervention by my senior resident. So when this patient came back after 2 days later, he presented with severe acute anterior uveitis, and you can see here the fibrinous reaction here. So this is very important to understand that the subjective symptoms matters. So usually in cyclitis occurs when the pain and photophobia during near distance activity like reading and writing, it increases. And the patient with recurrent attack of uveitis commonly recognize this pattern, and they can come at early stage and report to the doctor saying that I am having this difficulty. The similar complaint can be faced, a similar complaint often complained by the patients with sympathetic ophthalmia also. So the most important learning point from this case scenario is do not ignore the subjective symptoms of uveitis patients. Eye is the window of systemic disease. You have to understand that many of the time the ocular manifestation can be the initial presentation of a systemic disease. The management of ocular inflammation is not sufficient. The diagnosing the systemic disease, starting effective treatment at right time can save not only the eye, but the life of patient also. So one must understand that, and don't forget to look beyond the eye while treating a case of uveitis. Now here, the 2 case scenario here you can see, one is the anterior uveitis with small capes and significant conjunctival hyperemia, and second is the diffuse scleritis. Now, if you ask me the cause for this uveitis, the first one was brimonidine associated uveitis. The second one is biphosphonate associated scleritis. So there are certain drugs which can cause uveitis, and one should not miss that. So the number 5 point is do not ignore the history of current medications while treating a patient of uveitis. Always take the history of drug use. Now again, I'm showing 2 case scenarios. The first one is a 5-year-old child presented with gradual diminution of vision. You can see here there are a lot of fluffy materials in the anterior chamber. The child was diagnosed as a granulomatous uveitis and treated with topical steroid and cycloplegic. The second case I'll show here, a 62-year-old male presented with gradual painless diminution of vision, diagnosed as ocular TB, treated with oral steroid and ATT, and the gentleman was not responding to the treatment. Now, both this case scenario, one is anterior uveitis like picture in a child and posterior uveitis in an elderly individual. So when we did the tissue biopsy, the ACTAP in that child showed the presence of malignant cell, and it was a case of diffuse anterior infiltrating retinoblastoma. The second one, the posterior uveitis in an elderly child, the vitreous biopsy revealed it was a case of intraocular lymphoma. So what we learned from here, that do not miss uveitic muscularity. Always maintain high index of suspicion while treating a case of uveitis, treating uveitis cases in children and elderly patients. Here is another patient, is 27-year-old female presented with diminution of vision. She also complained of occasional headache, diagnosed as leakage elsewhere, and started on oral prednisolone 60 mg per day. So you can see here the picture, clinical picture here. The doctor suspected the VKH because the patient was giving occasional history of headache also. So when the patient came to us, we did a fundus fluorescent angiography, and you can see the multiple pinhead leak which are increasing in size and intensity in the late phases. So it was a case of multiple leak central serous chorioretinopathy. So one should not miss CSR, but the lesson we learned here is do not forget to perform an FFA before treating a case of posterior uveitis. So always treat inflammation before planning a surgical intervention, because if you operate a case with significant inflammation, it can lead to severe inflammation, delayed healing of the wound, pupillary membrane formation, ciliary body shutdown, hypotony, or it can lead to cystoid macular edema also. So the number 8 point is do not operate on an inflamed eye. This is another patient, a 35-year-old male. You can see here the patient presented with a severe scleral congestion. There was an anterior chamber reaction also. So we investigated the patient, diagnosed it as everything was normal, particularly the vasculitis and systemic rheumatic disease workup was normal. So we diagnosed him as a idiopathic diffuse anterior scleritis, started on oral steroid and topical steroid, and seen again after 2 days of oral steroid, the patient complained, the pain, ocular pain and subjective symptoms actually reduced with this oral steroid. And we just asked him to come again for follow-up. The patient came back again with severe excruciating pain on 3rd day. And this was the diffuse congestion, as you can see here. And you can see here this appearance of yellowish white nodule here on the temporal side. So when we aspirated that material and sent for culture, it was a case of Pseudomonas aeruginosa, which was sensitive to ciprofloxacin. With ciprofloxacin, we could manage this case, and at 2 months of follow-up visit, there was no ocular pain and resolved scleritis. So this was possible because we asked the patient to come for follow-up at regular interval or monitoring the patient at very closely. So this is the 9th point. But do not forget to monitor a patient closely when you are not sure of the diagnosis. Always ask the patient to come frequently to your clinic and examine the patient as frequently as you can. The last case, a 23-year-old male presented with severe pain, redness for 1 week, and there was a history of intravenous pyelogram for kidney ailment 1 month back, and the patient was started on steroid elsewhere and injected steroid. So you can make out from the picture that it was a case of endogenous endophthalmitis. So I was curious enough and asked the doctor to send me the photograph at presentation. The referral doctor was kind enough to share the photograph with me. And you can see here it started with a subretinal abscess and it flared up when the patient was subjected to steroid therapy and local steroid therapy. So as Hippocrates said that don't do harm. So this is very important while treating a uveitis. You have to understand that you can't inject local steroid without ruling out infection. This is very important in treating a case of uveitis aggressively. To conclude my slides, I'll just recapitulate all the findings again. The fundus examination in all cases of anterior uveitis is mandatory. Examination in non-dilated pupil may help in uveitis, so always try to examine the patient in non-dilated pupil. Never ignore the subjective symptoms of uveitis patient. Look beyond the eye, try to rule out the systemic cause. Always keep drug-induced uveitis in your differentials. Keep high index of suspicion for uveitic muscarate, especially in patients, children and in elderly individuals. Always obtain a FFA while treating a posterior case, a posterior or panuveitis. Do not operate on an inflamed eye. Monitor a patient closely when you are not sure of the diagnosis or cause of uveitis, and do not inject local steroid without ruling out infection. I would like to thank Dr. Sam Snowman for inviting me to this wonderful webinar. Thank you.
Thank you, Dr. Partho, for your nice and interactive session. Very interesting topic you have discussed with us. It will be very helpful for the who are practicing and for the junior colleagues and residents will be watching this. These tips are the very important one. So I'd like to invite our next speaker, Dr. Rina La Distinora. She'll be talking on ocular tuberculosis. Thank you. Dr. Rina.
Hello, Dr. Rajit.
Yes.
Yes, I think it is better to discuss on this topic now, then we will shift to the next presenter.
Okay, it's okay.
Okay. So
Rina, we can wait for 1 or 2 minutes.
Yes.
If
So,
anybody having any question, anything, you can
yes,
ask.
Excellent presentation, Professor Partho Pratim Datto. I have a questions to you. Actually, sometimes it has been asked to the residents or the students that how can you differentiate between the white uveitis like Fuchs uveitis syndrome and glaucomatocycletic crisis? Because these are the very asymptomatic but very damaging uveitis. Can you please tell on this, how can you differentiate between the early case in the Fuchs uveitis and glaucomatocycletic crisis? It has been asked in the Facebook Live by our residents.
Yeah, actually, sorry, I did not get it. The differentiating between
Fuchs uveitis and glaucomatocycletic crisis.
Fuchs uveitis and
glaucomatocycletic post-Klausman
crisis.
Yes.
The Fuchs is you have to examine the patient in non-dilated state. So main problem with Fuchs is often we go by the terminology that Fuchs heterochromic iridocyclitis. So often it's heterochromia in darker individual or in patients in like our country is often difficult to. This heterochromia can be very subtle. So it can be very difficult to differentiate between the heterochromia. This is number one. The second is that you have to rely on various clinical signs. Like you have to, as I said, you have to look at the blurring of crypts near the polarity. You have to look for the other patterns of iris patterns. And the second, another misconception occurs because when we say that it's an iridocyclitis, often the Fuchs patient can present with some amount of very minimal vitreitis or sometimes vitreous opposites. So which sometimes we think it as a vitreitis and we diagnose it as a different uveitic entity. But minimal vitreous inflammation or vitreous opposites can be seen in Fuchs uveitis. But mainly the anterior segment, you have to rely on the stellate capes, the keratic precipitates crossing the midline, distributed diffusely, and the iris topography you have to see, the blurring of crypts and other things.
And just I'm asking another interesting thing. We know most of the uveitis, the KP usually they have a tendency to accumulate in the lower part of the cornea. But in the Fuchs, why it is distributed all over the endothelium?
Two cases, whenever there is a diffuse distribution of KPs, it basically occurs in two conditions: the viral uveitis and Fuchs uveitis. So it's always better to understand that when you are seeing the diffuse uveitis, it can be remember of two conditions. One is viral, another is Fuchs.
Thank you. Very important points.
I have
I have a question to Partho Pratim Majumdar and Professor Sharfuddin Ahmed.
Yes,
you have told that don't operate on the inflamed eye.
Yes.
If there is an inflammation, that is uveitis, how long will you wait for operation?
For general ophthalmologist, I'll suggest you better, you have to make sure that the eye is quiet for at least for 3 months.
Yes.
And then you operate, or 6 weeks minimum. Yeah.
6 weeks to 3 months. Thank you very much.
Professor Hussain?
Yeah, very nice presentation by Professor Partho Pratim. My question is regarding, you showed the case of Herada and you found that it's not Herada, it's basically multifocal CSCR. Am I right?
Yes.
So my question is, was it bilateral or it was unilateral?
That case was, surprisingly, it was a bilateral. So that's why I selected that case. So very rarely it can happen. It can happen that the bilateral CSR, though I understand that it's very rare, can occur with similar presentation. And sometimes if you are relying on only headache, these patients can give a non-specific history of headache.
Yeah.
So it's always better to do a fundus fluorescent angiography before treating such cases.
So very interesting case. My second question is regarding how you proceeded for this multifocal bilateral CSAR in this case for management.
This case was difficult. One eye, the vision did not improve after that. Other eye, we did focal to the leaks.
Okay.
So, yeah.
So it was young patient, yeah?
Yeah, young patient.
Okay, thank you. Very nice. Thank you. Nice presentation. Good.
So
there is a question for you, Dr. Partho. There is Dr. Midas is asking about can we use systemic steroid in case of acute anterior uveitis in a short course, while and when it is indicated? Is it?
Yeah.
Can you use?
Yeah, definitely you can use, but you have to see that if it is responding to topical treatment, why you want to use. So the first criteria is the anterior uveitis is not responding to a topical steroid and cycloplegic, then you think about oral steroid. But before oral steroid, there are other options also. You have to explore those options. Most importantly, what uveitis you are dealing with. The anterior uveitis is due to what? That is very important.
Okay.
Professor Vishali Gupta, do you have any comments on this?
Yeah, can I?
Professor Vishali?
Yes. Very good presentation, Professor Majumdar. I would just like to add a couple of things. That examination of undilated and dilated eyes, pupil examination, undilated and dilated pupil examination of both eyes in any uveitis case is mandatory. So not just the eye which is involved, but the other eye also does need a very thorough examination. And about use of steroid in acute anterior uveitis, very correctly said that multiple factors should be taken into account. And laterality is one of the very important factors in deciding whether we should go beyond topical steroid or just keep ourselves restricted to topical steroid itself. And also in quite a few pediatric anterior uveitis, it is very difficult to manage with topical steroid alone, and periocular steroid is not easy in children. So there, after ruling out any contraindication of oral steroid, we should very seriously consider using systemic steroid as well. Thank you.
Professor Vishali Gupta?
Yeah, I think everybody has been, it has been said very beautifully by Dr. Partho. I would just like to add, like what Dr. Shah is mentioning about the pediatrics. So when we are talking about the children, we have to remember that many times there is compliance issues, like children don't take tablets, and you have to make sure that parents give it to them under supervision. And secondly, now in our part of the world, we are moving on to biologics very fast, because many of these children you cannot really treat with systemic steroids because of their growth and other issues, but you have to be very, very aggressive. Children do not complain, and they do not complain because they do not want to see a doctor. And uveitis, unlike adult, doesn't cause pain and redness in children. So you have to be very aggressive on them, and don't hesitate to start biologics as early in the course of the disease as possible. That's all. Rest all has been covered beautifully.
Thank you. Next speaker.
Next speaker. I'd like to invite Dr. Reena to deliver her talk.
I would like to thank Bangladesh Society for inviting me. So tonight I will deliver my talk about ocular TB, whether it's TB or not TB, and try to look for the clinical signs and biomarkers. So the problem is there's no single gold standard diagnostic test for ocular TB, as we all know. first we need to look for the suggestive clinical signs. And if we found MTB inside of the eye, we call it confirmed TB. And if we see no TB inside of the eye, but we found it somewhere else in our body, or there's evidence in chest X-ray with the immunological response test positive, it is probable TB. But if we only found one of them, we call it possible TB. But first, we have to exclude other etiologies. But the problem is these clinical criteria or the clinical manifestation individually, they cannot be diagnosed as ocular TB. So I tried to look whether there's a clinical signs for ocular TB by seeing the retrospective study, which were respond to ATT. And I also will mention good data from collaborative ocular TB study, COTS, which were led by Dr. Vishali Gupta. And they explain which clinical signs will give a good response to treatment and what are the consensus from all experts from around the world, how to start treatment in which clinical scenario. So the clinical signs that I think worth mentioning is first choroidal granuloma. This is an example from Indonesia patient, female 13 years old with miliary TB. We can see the choroidal granuloma and multifocal choroidal granuloma, and it responds well after giving ATT. So choroidal granuloma has been reported in many countries, including in China. They found that it is often found in young patients and had active systemic infection. And also in immune deficiency, like HIV, it is more associated to choroidal granuloma. And also in other countries, they found also TB with HIV. They will find more uveitis that in shape of granuloma. And with treatment with anti-TB in those patients, anti-TB alone will give a good response. And also from COTS study, they found that among all posterior involvement in ocular TB, the choroidal tuberculomas, as we can see, if we give the ATT, it is much less likely to fail than if we don't give ATT. So also in the consensus that is published just recently for tuberculoma or choroidal granuloma, everywhere in the world, at least there's TST or IGRA positive, or in endemic world where the chest X-ray is already positive, the expert will tend to, they reach an absolute consensus to start the anti-tuberculosis. That is the first clinical manifestation. The second one is the anterior uveitis. Many reports, they are associated with both active and latent TB. But there's also reported a recurrent anterior uveitis even after ATT. So what are the reports from the study? It is associated with active TB infection elsewhere. So anterior uveitis is possible in active TB. And also it will give good ATT response, especially in a Singapore study, if they found anterior uveitis, anterior scleritis in both IGRA positive and TST positive, the ATT treatment respond well. And also in COTS, there's an absolute consensus. If there's a recurrent episodes of anterior uveitis with positive PPD and IGRA, and also evidence in the chest X-ray, most of the experts will have an agreement to start treatment. The next one is the occlusive retinal vasculitis. This is an example of a patient in Indonesia, male 35 years old, IGRA positive, HIV negative, and other workup was negative, but there's no active TB elsewhere. But when we start the anti-TB and also corticosteroid, the eye is improved. And this is a study by Dr. Gupta. They found that tubercular vasculitis was associated with vitritis, snowballs, neuroretinitis, and focal choroiditis. In these cases, ATT should be initiated. What about in COTS data? They didn't find, and they found that ATT response varied in tubercular retinal vasculitis in different areas, such as In Asia, when ATT used, it is giving a good response, but not in the West country, where it is almost the same between giving ATT or not giving ATT. So after the Delphi technique gathering, there's only two absolute consensus about retinal vasculitis. If it's active retinal vasculitis in an endemic country where the PPD, IGRA, and radiology positive, the experts tend to treat those patients. And also, even though there's no availability of the IGRA, they will tend to treat the patient. The next one is the difficult one, the intermediate uveitis and serpiginous-like choroiditis. A study by Dr. Sumiava Basu found there's a progressive ocular inflammation, even the ATT was given, especially in intermediate uveitis and also in serpiginous-like choroiditis. There's anecdotal reports also association the condition with diabetes mellitus and even systemic lupus erythematosus. So there is a possibility of coincidental or immune deviation of the host that makes serpiginous-like choroiditis is hard to be treated. So how do we precisely tell it is TB? So if we see, maybe there's a future possibility of immunological marker also, because as we know, infection disease is like a triangle theory. There's a part of host response, is a part of agent response, and the environment response. So I did a study also to see whether we can see something from the host response. So we look for the type 1 interferon inducible gene expression instead of only IGRA. So type 1 interferon is more to the innate immunity response. We found that if we see all the gene response between the healthy control and patient that have active pulmonary TB infection, we can see that by doing machine learning, it can differentiate between the healthy control and the active TB control with these 10 genes. And we can see if it's having uveitis TB, but also active pulmonary TB, they will gather together with all the active pulmonary TB. So these genes have potential to differentiate between the two patients. And also there's a study by Dr. Agarwal under Dr. Vishali Gupta supervision also, that they found if the serpiginous choroiditis treated with ATT and oral corticosteroid, there will be a paradoxical worsening if there's an interferon gamma peak at 1 week and TNF alpha peak at 3 weeks. So at the end, at the other side of the coin, there's an hypersensitivity other host mechanism. So whether to see TB or not TB, we can see both from clinical signs and potential biomarkers. In direct infection, most of all, it can see in HIV or in children. The clinical manifestation is more to choroidal granuloma or tuberculoma. But at the other side of the coin, there's a more hypersensitivity reaction, which will need more corticosteroid treatment. And also there's a lot of paradoxical worsening reaction. And disease can be seen with biomarkers also, where the direct infection with that is having a choroidal granuloma or tuberculoma manifestation, it will have high type 1 interferon gene expression, while at the other side, there's an hypersensitivity, which have clinical manifestations such as intermediate uveitis, serpiginous-like choroiditis, and paradoxical reaction. Probably there is a high cytokine interferon gamma and TNF alpha reaction. So I think this is the end of my presentation. I hope it is clear, and look forward for your question.
Thank you, Dr. Rina, for your excellent presentation. So I like to invite Professor Dawn to give her expert opinion regarding the topics.
Professor Dawn Lim.
Yes. Yes. Very good talk, Dr. Rina. Thank you for the very good talk. I just want to find out, I mean, amongst consensus amongst all the panelist members here, that because we do know that there are some signs, for instance, a choroidal granuloma if present in the presence of, let's say, a T-spot TB test. Okay, so now the recommendation would be to commence anti-tubercular therapy. Do everybody stick solely to ATT, or do you monitor still for the potential probability, the less likely of a paradoxical reaction, and still offer to start systemic steroids in such individuals? What would be the approach of the other members of the panelists?
Okay. So I'd like to invite Dr. Professor Vishali Gupta for her expert opinion regarding the issue. You have more.
Thank you, Reena, for the beautiful talk, which I thoroughly enjoyed. I think in answer to Dr. Lim's comment, Reena has already shown two beautiful spectrum of the disease. On one hand of the spectrum, what we have is the active infection, like we have the granuloma or abscess. Now, if that is the situation, I will not be in a hurry to start steroids. I would give anti-TB drugs, but the experimental data has shown that these granulomas are dependent on VEGF. And there is a zebrafish model with the granulomas that if you cut the VEGF supply to the granuloma, they just disappear without any anti-TB drugs. So we have a very interesting experience of managing these granulomas with anti-VEGF. They respond, but they come back after a year or so, the recurrence. So I would treat them with anti-VEGF and ATT and will not be in a hurry to start steroids. And in no way I will inject intraocular steroids in patients with active granuloma. On the other hand, there is a hypersensitivity kind of reaction like serpiginous, like choroiditis. And I also know that if we start them on anti-TB drugs, it is going to show paradoxical worsening, and there are no active bacteria multiplying there. So those are the situations, if it is very close to the fovea, we actually start giving steroids and add ATT on top of it, so that we minimize the risk of paradoxical worsening. So that's how we do it with us.
Thank you.
Next speaker.
So I'd like to proceed for the next talk. Dr. Ranju, she'll be talking on seasonal hyperacute pan-uveitis SHAPU. Dr. Ranju, please.
Yeah. Thank you, Dr. Rajiv, Dr. Noman, and Dr. Partha for giving me this platform. So today I'll be talking on seasonal hyperactive pan-uveitis, or which is also known as SHAPU. And it is in fact different from other kind of uveitis because it has got its own peculiarity. The first thing was like when it was first identified in 1975, then after it's occurring in a cyclical pattern every alternate year in odd years. Like that, the last outbreak was in 2019, and we expect the next outbreak of SHAPU in 2021. And it's not that the whole 2021 year will have the outbreak of SHAPU because it has got particular seasonal occurrence usually in the autumn and in the early winters. And it is one of the most commonest cause of pan-uveitis in Nepalese pediatric population with no gender predilection. Surprisingly, it's only one eye that is affected on only one-time disease. So there is no recurrence, reported history of recurrence. And how does it start? It starts suddenly with redness without discharge, which is an important point to differentiate it from conjunctivitis. And the pain is also minimum. This is an important point to differentiate from endophthalmitis, where the redness is also sudden and sudden onset. But the loss of vision is very dramatic and profound within a week. And it usually presents like white pupil in a red eye. So leukocoria in a red eye, like in the picture that you see at the top, unilateral redness with leukocoria, that is different. That is a point to differentiate from other leukocoria and the pediatric population, like in case of retinoblastoma. An important point is there is no preceding history of trauma or surgery, which help us to differentiate it from exogenous endophthalmitis. And the cases are usually immunocompetent. So this helps us to rule out from endogenous endophthalmitis. But to be very honest, we don't know whether it's an infective etiology or immunological etiology till date. So this is how a child presents with sudden onset of unilateral redness, and when we examine, we see that the anterior chamber is filled with fibrinous exudate, hypopyon, leukocoria, and the vitreous. In the vitreous also there is a dense vitreous exudation. So what do? We take it as an ocular emergency. We take the child immediately, or if it is an adult patient, on general local anesthesia, and for a child on the general anesthesia. Like in the picture in the top left, you can see this pus being aspirated, yellowish color pus from the vitreous cavity. In the same sitting, we give the intravitreal injections. If we directly go with the core vitrectomy, we don't want to delay by weeks or even by days, because we are feared with the development of total retinal detachment followed by hypotony and phthisis bulbi. So the problem here is, like, it's not that they come just one case in a day. They may come in clusters, like 5 cases or 3 cases per day during that outbreak time. But the better story, mercifully, it's the only one eye and one-time disease in that particular eye. And the good news is, if we can get the cases in early stage, we can save the vision of that child. But the bad part is the treatment for this kind of uveitis is not available in all the eye centers of Nepal. They need to be referred to a particular center with a vitreoretinal setup. And even if they are available, it might not be affordable to all the Nepalese population. So by the time they are referred to a tertiary level hospital, it could be a delayed presentation with loss of sight and with cosmetic disfigurement. So how does it present? It presents from anterior to posterior involvement. So early presentation, here we are talking in days. So early presentation within 2 days could just be mild anterior chamber reaction, but by 7 days, there could be dense anterior chamber reaction with or without hypopyon, but still the retina is visible. But if it is more than 7 days, it's already there is presence of leukocoria with no view of retina. So our management also depends upon the pattern of presentation. We yet don't know whether it's infective or immunological condition. So what we do is a blanket therapy with both antibiotics and anti-inflammatory. Even if we assume that it's an infective condition, the toxins produced by the microbe can cause inflammation. So we give both antibiotics and anti-steroids. So for early case, we manage topically, and in intermediate case, we add in the systemic medications with systemic steroids along with the oral steroids with intravitreal injections. And in late case, we definitely need to do core vitrectomy with or without lensectomy. This is the protocol that is practiced in my institution. So we try to combine the existing knowledge on SHAPU, and we published this article in 2018, and this was later awarded by the Japanese Ophthalmic Society also. We wanted to make SHAPU, spread the knowledge of SHAPU to among our international colleagues also, so we could incorporate this disease in AO iWiki, and this page again got awarded with the AO International Ophthalmology Competition Award. So what are the risk factors of SHAPU? For that, we conducted a national level study in 2017, and we looked for both the biological as well as the behavioral risk factors. And we found that yes, there's no difference between a male child or a female child presenting with SHAPU, but it's, as we said earlier, it's basically a disease among children because 71% of them were children, less than 16 years. And the youngest one was a 38 days old child. And this we could publish in ASIO. When we looked at the potential risk factor, we identified that those cases of SHAPU, those cases who had direct physical contacts with white moth had 6.8% higher chances of developing SHAPU. So one of the potential risk factor was white moths, and this is now published in ophthalmic epidemiology. So what are the moths that we are talking about? We are talking about these white moths. These are the clinical pictures which are provided to us by the patient party. So these moths were found in their environment, in their bedrooms, when the person had developed SHAPU. So these are the white moths with black striation, probably the Gasolina chrysoporia variant, and it is basically the female variant of white moth that causes SAPU. Why female? Like in the picture you see at the top left, these yellow are the eggs, this brown are the hair particles. So it is said that the mother protects the eggs. So this brown hair particles or the setae or the spine, they contain toxins, inflammatory materials, which and these hairs are easily detachable in the environment. So anyone who comes in contact can develop SAPU in that particular geographical location and particular in that particular population. So we could document the presence of this hair in the different layers of cornea in this patient of SAPU, and even it was confirmed with anterior segment OCT, and later it got published in IZO. So the moth saga is just a beginning because it has a lot of mystery within itself. We yet don't know which is the particular species of moth that is causing this disease and why this moth population suddenly increased in odd years during that particular time, and exactly how the moths are causing disease. Are they releasing toxins causing hyperacute immunological reaction, or they are acting as a vector for transmission of microbe to the intact ocular surface, or are they acting as a uveatogenic antigen? The mystery is yet to solve. So when we try to decode the SAPU theory, it's always a battle between a pro-infective origin and pro-immunological origin. Maybe we think that it could be a combination of both. Yes, there could be pro-infective origin because at various stages of SAPU outbreaks, bacteria and virus were identified. There is no common organism that is confirmed in every outbreaks, but it was Streptoneumoniae, Staph aureus, varicella zoster, and even annulovirus that were detected. But the pro-infective, but the points in favor of pro-immunological cause is its painless nature and its rapidity. So the mystery that is yet to be solved for SAPU is what is in fact, is it an immunological condition or infective? If it is infective, is it bacteria, virus, or fungus? If we confirm it's solely to be an infective origin, we'll just start with the antibiotics. If we can, and we don't need steroids for that. If we confirm just as an immunological condition, why do we add on patient with the antibiotic to increase the antimicrobial resistance? And what is the role of moth in SAPU condition? Why only children? Why unilateral? Why no recurrence? Why seasonal? And why reported only from Nepal? So if anyone wants to answer for this question, let me say beforehand, I have no answers to these questions, but we are working on it. Hopefully with this UAP award, we are working on the immunobiomarker sequencing and phenotyping in SAPU. So hopefully we'll get the answers for those questions in future, so that this innocent faces, this innocent child will not develop blindness due to SAPU. Finally, I end with this picture. This was one of our SAPU patient who had lost sight in his left eye because he was presented late. But his aim is to be an ophthalmologist, and his wish before discharge was to examine my eye. And look how intelligent child is. He's correctly holding the joystick in his hand. And one more thing, this child at the bottom, he was diagnosed as leukocoria, he was diagnosed as retinoblastoma elsewhere, but it was a SAPU case. He lost his sight, he lost his cosmesis, but he has not lost his smile. So this gives us an inspiration to work for SAPU. I thank you all for your patience hearing. Thank you.
Thank you, Dr. Ranju, for your very interesting and very attractive all this presentation. Now I like to ask Professor Shah sir for his valuable comment regarding the SAPU. Professor Shah.
Well, first of all, I would like to congratulate Dr. Ranju for a very good presentation. You know, right from the time first case was reported from Nepal, and I do remember the case was from Pokhara. So the SAPU is surrounded by mystery, very correctly told by Dr. Ranju. We are not able to reach any conclusion about its etiology that is amply evident by her presentation. Very interestingly, it was diagnosed as case of uveitis, and until 1993-94, the cases were being treated with steroid, topical, periocular, and systemic steroid. Few cases were subjected for vitrectomy with universally poor results. Almost all the cases prior to 93-94, whatever I got to follow up, I could see just diagnosis mentioned as SAPU and the eye becoming hysical. And even I, with Professor Upadhyay, Madan Upadhyay, we tried to do vitreous tapping and for culture. And in isolated cases, we did find that there were bacterial presence. And then in 93, I started treating these cases as endogenous endophthalmitis with systemic antibiotic, intravitreal antibiotic, topical and fortified antibiotics, along with systemic and topical steroids. And I still remember the son of a flower florist. He, for the first time, showed good result with visual recovery up to 6-9. And that was the case which was treated as bacterial endophthalmitis, even though we did not have positive yield of the organism. And this happens in many of the endophthalmitis, where we made kind of routine that we would treat these cases as bacterial endophthalmitis. And whatever few cases we got positive outcome in the form of vision, salvaging eye, all those cases without exception were the cases which were treated with antibiotics in through various routes. So even today, I think most of the cases are being treated as endogenous endophthalmitis in the form of systemic antibiotics, intravitreal antibiotics. Yet the result is not universally good so far. However, the silver lining is whatever few cases we are able to salvage the eye and the vision are the cases which are treated with antibiotics along with steroid through various routes. Well, the mystery is still surrounding this disease, and I think maybe for coming some time, it will be an enigma to find out the etiology of this disease. Till then, I would suggest that a thorough investigation, and since we don't have any other evidence where we get positive outcome, we continue to treat these cases as bacterial endophthalmitis. That's all I have to say. If there are any questions, I may respond. Dr. Ranju and various other people in the panel, they can respond about this disease. And let me add one more thing. Though these cases have been reported from Nepal alone, I had the privilege of seeing few cases which were from the neighboring part of India, and all the clinical features and the age and the gender predilection, all of those were same age that of Nepali children, but I have seen children from India suffering from this disease called SAP. Thank you.
Thank you, sir, for your excellent briefing and excellent topics about all these things, your presentation about the Ranju's topic.
Professor Hussain
I
is
like to
correct.
now I like to invite Professor Kakon for his expert opinion regarding the seasonal hyperacute pannivitis.
Thank you. First, I congratulate Dr. Ranju and Professor Shah. These are very rare cases, and I am doubt it has been gone through my slit lamp examination, but I couldn't find. Now, when Dr. Ranju was presenting, I thought, oh, I missed one or two. Maybe those were Shapu. So I really feel embarrassed about that, but at least I know that it is there. So hopefully in future I will try to add number of cases in your study. And I really congratulate Dr. Ranju and Dr. Shah for excellent work and the part of world they are working and we are working, and the patient social economical status and how to follow these patients and how to get the funds and to find this disease and its etiology and all what they are doing. Really commendable and highly appreciate your efforts. Just my single question, when you do the vitreous biopsy in these cases, what usually you found in the biopsy specimen? Can Dr. Ranju?
Like to tell?
So we are sending the vitreous sample.
Hello? Yeah.
This is hello?
Yeah.
Yeah. Thank you so much for your nice comments. And we send the sample both for the bacterial culture and the fungus culture. So around out of around 3 cases we have also, and the blood sample also to rule out endogenous positive for Staph aureus, both for conjunctiva and the vitreous, and only one sample was positive for for Staph aureus in the vitreous. We have not yet identified the fungus, but there has been reports in 2011 where they had identified the toxinovirus in Rotterdam from the vitreous sample of Shapu patients.
So thank you for your nice reply. So I will try to join your work regard to find and search or hunting the Shapu syndrome along with you. Dr. Ranju, thank you so much.
Thank you, Dr. Ranju.
Thank you, Professor Kakon. Now I like to invite
Rajiv,
yes.
I have a question to Ranju.
Yes.
You told that this seasonal hyperacute uveitis is mostly found in Pokhara. In other parts of the Nepal or the border of the Nepal and India, did you get in what area it is much more? And August to December, there is the cold season in Nepal. So do you think there is the cold as well as the area where there is flowers or other things much more that can initiate this type of seasonal hyperactivity? Ranju.
Yes, thank you. Yeah, like we try to study about the geographical location of incidence of Shapu over the last few years, and we find that it is less common in the plain and the tropical regions and more common in the subalpine areas with the altitude of 2,000 to 3,000 meters. And when we try to be more focused, why only in Pokhara, then one probable clues for it, like Pokhara is like there is abundance of caves in Pokhara, and that caves, the bats in those caves is one important link for us to get connected with the white moth. So hopefully we'll solve out this history also. And yes, you are correct, it's mostly in the post monsoon season, that is in autumn, that starts from from July to August, and it ends with the peak of winters, that is the Shapu cases usually end by January. Yes, there is some climatic association also, and that climatic association has something to do with the breeding time of those moths in their life cycles. So these are under study. So hopefully we'll crack it soon.
Okay.
Can I add a couple of things?
Yes, sir.
Very nice question asked by Professor Hussain Ahmad Hakan. In the vitreous samples, apart from the organismal isolation part, about the cellular predominance, there were varied pictures. Like there were cases where we saw the predominance of white blood cells polymorphs, and there were a few cases in which there was lymphocytosis, predominance of lymphocytes in the vitreous. And of course, necrotic cells were there. So that doesn't give any clear-cut picture whether it is pyogenic or immunologic. That is another confusing things which lead us nowhere as far as diagnostic part is concerned. But one thing is there, that the cellular pattern in the infections over the period do change. That happens in the tuberculosis, that happens in the other cases. And if we go by the reports of earlier chronic uveitis, even the T cell patterns, helper T cells, suppressor T cells pattern, they also change in the vitreous with the duration of the inflammation and infections. So cellular pattern solely should not be taken into account, however, can be correlated with the duration of the disease, and then it may be helpful. Now, the second thing is that which areas it is more prevalent. Very correctly said by Dr. Ranju, it is more prevalent in the mid-hills of the Nepal, not at the very high altitude and not in the plain areas so much. However, we have seen the cases from almost every part of the Nepal. And also, for initial few years, we were concentrating and saw the cases in children group, but we have had, as Dr. Ranju had also shown in her presentation, few cases where adult patients also with the findings consistent with the SAPU and treated in the line of SAPU, and the results were better as far as my experience goes in the relatively higher age group in comparison to children. And that is understandable that majority of these diseases where the patient is unable to communicate his part of the problem, there they are bound to suffer little more in comparison to the patients who are able to express their problems clearly. So yes, so that is this disease is seen almost every part of Nepal, but more common in the mid-hills of the Nepal. And we have also been seeing in older children and adult age group as well. Thank you.
Next presentation.
Thank you, sir, for your nice comment and all this thing. So I like to now invite Dr. Partho for his expert opinion regarding the issue. Dr. Partho.
Yeah, my knowledge on SAPU is very limited. I'm learning from Ranju.
Okay, thank you. I am so lucky that I got a chance to work with Professor Shah and Ranju during my residency and all these things. So I have little bit exposure and experience to work on that. I was to work with Ranju and me. We are in the same team. We used to do all these things, and Sir was our guide also at the same time. So I'm very lucky to see many cases during my residency. Thank you.
Have you seen any case in Bangladesh, Dr. Rajiv?
No, sir, not likely. We haven't found
So
anything like that.
I think we are missing it. We have to find it now.
Yeah, that's right.
Probably we have missed it in Bangladesh.
Yes.
Yeah,
Yes,
we missed
yes.
in Sri Lanka. Yes, but in
Yes,
future
yes.
we'll try to find it out in our country.
Yes.
We find many cases from the lowland also, sir. During these things, the end of the rainy season, usually they used to come, and usually patient used to come at the midnight and all this thing. Early morning, they used to travel from the far and when we was on duty, we used to find all the cases the middle of the night and all these things. So we have nice memory regarding all these cases and all my residency. Thank you for all these things. Now I like to invite now our next speaker, Dr. Zaidur Rahman Ranju, to talk about the clinical approach to a patient with retinitis. Dr. Pannu. Pannu, can you hear us?
Dr. Pannu, please unmute yourself. Unmute yourself.
Unmute. Technical team, please help him.
Please unmute yourself.
Pannu bhai, apnar unmute karen. I'm on a host to help him.
On the left lower corner, there will be sign of mic in your computer. You can click on that.
Asif, can you help him?
Hello, Dr. Yes, thank you. Thank you.
Thank you,
It
we can hear
is
you.
audible. Just share your screen. Thank you.
Nice. Yes, can.
Am I audible?
Yes.
Yes. Nice.
Can I start slideshow?
Okay. Good evening, everybody. Though the retinitis is not very common in our clinical practice, but the devastating nature of this may causes ocular morbidity, and so very early diagnosis and treatment may salvage the vision of many patients of retinitis. For evaluation of the retinitis, we may look after to size, number, and pattern of the lesions, size, morphology, pattern of capes and aqueous cells, and location of the lesions, how it progressed, and associated other signs, aqueous and vitreous cells, vasculitis, retinal hemorrhage, and status of optic disc. This is an anterior segment photograph. There is a granulomatous KP on the arch triangles, as like it looks like the granulomatous anterior uveitis, as Partho showed before, that after fundus examination, that we can see a focal yellow-white area of retinal necrosis on the center of the macula and with vitreous haze. Clinically, we may say that it may be a case of toxoplasma retinochoroiditis. So many types of this type of retinitis may present with tuberculosis, sarcoidosis, or syphilis, but in most of the cases, the retinitis we encounter is viral retinitis. That may be necrotizing herpetic viral retinitis or non-necrotizing herpetic retinitis. This 33-year-old lady presented to us with the redness and photophobia of the left eye. The vision was normal, but after fundus, she had granulomatous KP on in the endothelium. But on fundus examination, we can see that confluent area of retinal necrosis on the periphery, and there is also occlusive vasculitis here. And clinically, we may make a diagnosis of a case of acute retinal necrosis, which is a progressive disorder with retinitis, cause vasculitis, and also severe intraocular inflammation. And aqueous fluids was shown that it was positive for varicella zoster virus, and we have treated it with the oral valacyclovir and oral prednisolone and responded well. This case was presented with us with like this, and there is an extensive area of retinal necrosis almost throughout the all periphery, and with there is also peripapillary arterial occlusive arterioitis and disc swelling, and Usually, the acute retinal necrosis occurs in a patient, immunocompetent patient due to herpes simplex type 1, herpes simplex type 2, varicella zoster virus, and lastly CMV or Epstein-Barr virus. The clinical trial for diagnosis of acute retinal necrosis is rapidly progressive foci of retinal necrosis circumferentially, and severe vitritis and occlusive vasculitis. So after treatment with the oral valacyclovir and oral prednisolone, it is doing well. There is also barrage laser was done, but nowadays there is also a controversy about the barrage laser. But after in the same case, after stopping of the oral prednisolone, the patient developed cystoid macular edema, and again we have started oral steroid, and the cystoid macular was resolved. But unfortunately, this patient was developed steroid-induced CSR, and after that, the patient having repeated attack of cystoid macular edema, and we are failed to control that cystoid macular edema. This case was published in Ocular Immunology and Inflammation also. So my humble submission to panelists to give us a guideline that how we can manage a case of a cystoid macular edema in a case of acute retinal necrosis. Another type of necrotizing retinitis is progressive outer retinal necrosis, with here the involve the deep retinal layers, so it showing the opacification of the retina either locally located either peripherally or maybe centrally, and it is rapidly progressing. And note that there is no involvement of the vessels or and no or minimal inflammation. It is usually occurs in the case of AIDS or immunocompromised patients, and usually caused by varicella zoster, lastly by CMV or herpes simplex virus. And there is also an peripheral involvement of the progressive outer retinal necrosis. A 9-year-old young boy was diagnosed as acute lymphoblastic lymphoma after 4th cycle of having his chemotherapy. He presented to us with loss of visions in both eyes. The right eye was showing that resolving retinitis, but in the left eye there is extensive retinal hemorrhage with vascular occlusion, and there is also creamy white retinal necrosis, and we clinically diagnosed this case as a case of CMV retinitis. Also, we do ACTEP for virus, and the CMV DNA was found, and with the consultation with a hematologist, he was treated with the consultation with the hematologist. They have treated with the IV ganciclovir for prolonged period, and the patient was responded well. That leaving behind some scar in the left eye, and there is some sclerosed vessels, but in the right eye there is fibrosis and motile pigment epithelium. That this CMV retinitis is also present in a immunocompromised host like HIV or other disease like malignancy, or patient having getting chemotherapy or organ transplant or immunosuppressive drug, or even some rheumatological disorder like rheumatoid arthritis or SLE. Another case, there is a presented with a creamy white retinal necrosis here, and there is a clear retina in between these, and there is also some retinal hemorrhage here and posteriorly, and here along the blood vessels. This is a case. This is also a 41 years old gentleman and diagnosed as non-Hodgkin's lymphoma, completed 3 cycles of chemotherapy, but unfortunately the patients were having renal failure and severe anemic, so we could not start a systemic antiviral drug. We have treated him with intravitreal ganciclovir, but ultimately he developed optic atrophy in his both eyes. Another case of CMV retinitis with massive retinal necrosis with hemorrhage, and this patient was positive, HIV positive. She has already lost his other eye due to unoperable retinal detachment. That was that also the complication of that CMV retinitis. The CMV retinitis may involving all quadrants of the retina, and here a 36-year-old lady came to us with sudden loss of vision in one eye. We found that there is an area of retinal necrosis on the posterior pole and involving the macula and fovea, and there is also some cotton wool spot. And after diagnosis, after investigation, we found that both ANA was positive and double-stranded DNA was positive, and with the consultation of the rheumatologist, we have started the immunomodulator drug and oral prednisolone, though her systemic feature was dramatically improved, but the vision was not so good because of involvement of the macula. So the clinical diagnosis is very important for diagnosis of different type of retinitis. So correlation of clinical history, complete systemic and ocular examination may be help to early diagnosis of retinitis, and immediate treatment should be started in typical cases according to clinical diagnosis to prevent further complications and ocular morbidity, and prompt identification of infection requires analysis of intraocular specimens. Thank you everybody. Thank you very much. Thank you organizer to giving me the opportunity. Thank you.
Thank you, Dr. Jaidur Panno, for your nice interactive presentation. Now, I'd like to invite Dr. Niaz Abdur Rahman for give his expert opinion regarding the topic.
Niaz is there? I have
Yes,
a question to
I'm
Dr.
here.
Yes.
I'm here. Yeah, all right.
Sir, I have a question. Sir. From the students, there is an open question that how can a resident can differentiate between the retinochoroiditis and chorioretinitis? It's the open question.
Retinochoroiditis and chorioretinitis. Well, it'd be very difficult. I mean, they're all both of them are inflammatory diseases, and you look at the fundus, and if it's a retinochoroiditis, I think the cells in the vitreous would be a very important feature to differentiate between a retinochoroiditis and a chorioretinitis. And in case of chorioretinitis, I think the amount of uveitis would be less than the other. If I'm not mistaken, Dr. Vishali might expand on it about retinochoroiditis, but it's yes,
sir,
Vishali.
I want to add something, sir.
Yes, Jasmine.
Sir, for retinitis, the lesion is yellowish, while the caudal lesion is slightly orange or brown in color. The margin of retinitis is fluffy in nature, and there is more vitritis and vasculitis. Vasculitis is more common with retinitis. Okay, but vasculitis is not that much associated with the choroiditis. Though retinitis also spread to choroiditis, and choroiditis again spread to retinitis. And Pannu, Dr. Pannu, excellent presentation. I again want to add something with the ARN and PORN. The ARN retinal detachment is much more common with acute retinal necrosis, where it is not that much common with porn. Another one is porn is exclusively happened in immune compromised patient like AIDS, but ARN both in immune competent patient and immune compromised patient. If patient is immune competent, then Uveitis is much more aggressive one. This much. Another thing is CMV retinitis. CMV retinitis or CMV uveitis usually associated with high intraocular pressure. The intraocular pressure may be more than 40 millimeter of mercury. And one question, the expert opinion must be invited. The cystoid macular edema in ARN, how can we treat? When we treat ARN with steroid, it can help to resolve the cystoid macular edema, as the cystoid macular edema is a response of huge inflammation. That's enough. Okay, thank you.
Dr. Vishali Gupta.
Yeah, I think regarding the phenotype, whether it is retinitis versus choroiditis, both of them have already said most of the things. In practicality, I use OCT all the time. In retinitis, you will see the hyperreflectivity of the inner layers, and you will be surprised that you are seeing actually cells in the vitreous that you may not appreciate clinically. Whereas when it comes to the choroid, you will see the elevation of the choroid, mostly in the form of granuloma. So to me, it is very simple. If it is retinitis, it can either be toxo or Behçet's. If it is choroiditis, it is either TB or sarcoid. That is generally what you see in most of the cases. If you are thinking of a retinitis and you have this fluffy patch, which is yellowish in color and it is fluffy, you do not see the overlying retinal blood vessels running over them, and you may have associated vitreous cells, and when you do OCT, you have hyperreflectivity of the inner layers. You just do a good fluorescein angiogram and see if there is any leakage from the capillaries all over the bed. So if the capillaries are leaking, go for Behçet's, dig out the history. If it is a local retinitis, which is hypo to hyper in the late, it is toxo, and I would just treat this patient for toxo even if the phenotype is very typical. For choroid, most of the time in our country, it is TB or sarcoid, and I will not go into the details of it, but if you see a granuloma of TB, it tends to be single. On OCT, you see a huge oval granuloma, and you may have hemorrhages and blood vessels on the granuloma. That is very typical for TB granuloma. Sarcoid, on the other hand, produces small granulomas which are in the stroma. They are deeper, they are multiple, and they are more likely to be associated with vasculitis compared to TB. So these are some of the common things. Regarding the management of cystoid macular edema in ON, that will generally come by the time the acute viral retinitis is over. So it is a late phenomena which happens. At that time, to be very honest with you, I will not be giving steroids with lot of enthusiasm because there is a risk of recurrence of the virus. The virus is still somewhere in some ganglion in the body. So I would be very happy treating these patients with topical non-steroidal anti-inflammatory or with anti-VEGF therapy intravitreal if required for the macular edema. Thank you.
Thank you. Do you have any comment
Thank you,
on
madam.
Professor?
Thank you very much.
Professor Don Lim? Don Lim is, are you there? Dr. Don Lim?
Yes.
Yes.
Yes, Dr. Hello. I would just like to ask the question to Dr. Vishali. So I gather that anti-VEGF in this situation would be indicated for patients with cystoid macular edema secondary to viral retinitis. Would that be your usual approach?
Ton, I would be very scared of giving steroids to this patient because
Yes.
of the fear of the virus. I would try to treat it with topicals, and if it is not managed, if at all, I will give anti-VEGF. But to be very honest, I do not see cystoid macular edema very commonly in patients with resolved acute retinal necrosis. Fortunately, it's not so common.
Yes.
Dr. Rajiv, you can proceed.
Thank you.
Yes.
Thank you, Don.
Yeah. So we can proceed for the next speaker, the last speaker. I'd like to invite Dr. Shams Mohammad Numan to talk about the uveitic glaucoma. Please, Dr. Numan.
Am I audible? My
Yes,
slide
yes.
is visible?
Yes.
So firstly, it's my pleasure, it's our pleasure to have you with us here in this session of Fight Against the Fire. And actually, the Uveitis is like a fire, and we are all the firefighters, the world famous firefighters are accumulating here to fight against fire. And congratulations, I think we are going to be winning. And I'm really thankful to Dr. Parthopatim Datta Majumdar. He requested me to tell about the glaucoma. So I have no financial issues regarding this presentation. So uveitic glaucoma, my presentation topic. So I'm going to start with a case presentation. Mrs. X, 45 years female. He came with blurring of vision for the distance and near since 1 month. And she had a history of left-eye trauma with within stick 2006. And she had no other systemic illness. And she had some evidence of bilateral uveitis, especially in the right eye, peripheral anterior in 3 o'clock and 6 to 8 o'clock region. And in the left eye, there is some raised intraocular pressure, microcystic edema in the cornea, and also pupil 360-degree posterior synechiae with iris bombing. This is her picture. And we did the multiple peripheral iodotomy, young laser peripheral iodotomy, and with topical steroid and topical timolol maleate. And after 1 week, this is the angle structure in the right eye, occludable angle in the left eye, almost closed angle with the patent peripheral iodotomy. Still, the intraocular pressure was raised. And after 2 months, intraocular pressure is still raised, and we added another one anti-glaucoma medication. And after 2 months, patient had a history of pain, redness, and blurring of vision. And we saw there is also 360-degree peripheral anterior synechiae, intraocular pressure was raised, and we started treatment. And even with the treatment, the intraocular pressure was not very minimized, and we extensively we tried to diagnose the cases with EVA specialists, and ultimately we diagnosed the case with active non-granulomatous uveitis secondary glaucoma with cataract. And after reduction of the inflammation, and we just wait for the 1 month, and when the eye was quiet, and I just did the trabeculectomy, cataract surgery with mitomycin C. And that was the end result in the last visit. Though there was a advanced cupping, the intraocular pressure is 20 millimeter of mercury, and visual acuity was 6.9. That was the history. So what is the epidemiology? Actually, among the uveitis, 21.84% had a secondary glaucoma. Usually, this is the epidemiological study done by the Tonus Dada, and within them, the 8% is the uveitic glaucoma. So, and what is the age actually? The average age is 40 to 45 years. What is the cause actually? With increasing age, there is the imbalance in trabecular mesh function and inflammatory load. And the female has a more predominant in the secondary glaucoma due to uveitis. And what is the pathogenesis? There are 2 mechanisms: cellular and biochemical changes in the anterior chamber, and also morphological changes in the angle. And cellular and biomedical changes, what are the changes actually? The inflammatory cells from the leaked uveal tissue and the blood vessel that causes mechanical obliteration, and also increased viscosity of the anterior chamber due to increased permeability of the blood aqueous barrier. The protein comes onto the anterior chamber, increased the viscosity of the anterior chamber, and that caused the increased resistance to outflow. And also some inflammatory mediators from the lymphocytes and macrophages that causes some vasculitis and also some new vessels formation in the angle, that also causing some extra trabeculitis and trabecular fibrosis later on. And what are the morphological changes? In the open angle glaucoma, the morphological changes usually occurs due to trabeculitis followed by the trabecular fibrosis or sclerosis, and also it's very common in the angle closure glaucoma, 360-degree posterior, the posterior synechiae, then that causes the iris bombi, then causes the peripheral anterior synechiae, and ciliary body rotates forward, so that the secondary angle closure glaucoma thereby. So what are the commonest causes of secondary angle closure glaucoma in different secondary glaucomas in different uveitis? Usually in the anterior uveitis, the Fuchs heterochromia, idiopsyclitis, Posner's lodgement, infective uveitis, and arthritis-related uveitis, especially juvenile idiopathic arthritis. For the intermediate uveitis, sarcoidosis, tuberculosis, and the posterior toxoplasmosis and acute retinal necrosis, and the pan-uveitis, obviously in the tuberculosis, sarcoidosis, and Becher's, and also VKs is not very much uncommon in our country. And what are the signs and symptoms? You know, the blurring of vision. If it is a secondary glaucoma, the blurring of vision is the very earliest sign, and also pain, redness will be more, and due to intraocular pressure elevation, heaviness, and corneal edema, photophobia, and colored halos will be increased. If it is the presentation of the secondary glaucoma is very aggravation of the uveitis signs and symptom actually. And uveitis associated with glaucoma, or I want to discuss about the Fuchs heterochromic idiopsyclitis, Posner's lodgement, or glaucomatous-cyclitic crisis, juvenile idiopathic arthritis. These are the common scenario in our clinic: herpetic uveitis, sarcoidosis, and syphilis. So very interesting. We used to miss the Fuchs heterochromic idiopsyclitis and Posner's lodgement syndrome as there's the white uveitis, because there is no redness and the signs and symptoms are very few. In the Fuchs heterochromic uveitis, what we have already it has already discussed by the Dr. Partho, excellent presentation by him. It is unilateral and third to fourth decade, and heterochromy is a sign. And also the whole cornea, there is some stellate key piece find and some patchy atrophy. And when I do the gonioscopy, this is my personal experience, I used to see some very tiny blood vessels in the, these are not like new vessels, some incomplete blood vessels in the angle. And even though after gonioscopy, I feel there is some hemorrhage. This is even when we do the surgery, there is some unexplained hyphema in such cases, some unexplained bleeding from the angle. And there is also associated with increased intraocular pressure and also associated cataract. Gonioscopy, I have already told, the vessels in the angle, and I don't have any experience to fluorescent angiography of the iris, but different authors told that with fluorescent angiography, there is some areas of non-perfusion and leakage also. Management notes, steroid, as there is a very little inflammation, we don't, I'm not giving a very vigor, I have to deal with the UVA specialist, and I am dealing with the intraocular pressure only. Usually one or two medications, the intraocular pressure sometimes controlled, but if it is not controlled, then I have to do the filtration surgery as it is associated with the cataract. So I have to do the combined surgery after reduction of the inflammation. So glaucomatous-cyclitic crisis or Posner's lodgement syndrome, this is one of the very commonest cause I encountered in my clinic as a secondary open-angle glaucoma. This is quite a asymptomatic. Patient comes with the colored halos actually, and when I do measure the intraocular pressure, the raised intraocular pressure, patient has a history of discomfort and blurring of vision sometimes. And this is one of my study, published study about the glaucomatous-cyclitic crisis and elusive disease, our experience in management and outcomes. And these are some my findings: mild or no ciliary flash, corneal epithelial edema, intraocular pressure. Usually it is 40 to 60 millimeter of mercury, but it is a white eye. Open angle faint flare, fine keratotic precipitates. And some pathogenesis, it has been written in the different books, herpes simplex and cytomegalovirus are some causes and some are vascular causes. And investigation like a flukes uveitis, I don't have any experience of doing the such type of investigation. Irish angiogram, there is areas of non-perfusion can be found. And I used to manage it with the topical non-steroid anti-inflammatory drug. If it is sometimes it is not controlled. Sometimes I use the topical NSI steroid and oral non-steroid anti-inflammatory drug and anti-glaucoma medications. And then the third one, the common, usually referred from the pediatric clinic, juvenile idiopathic arthritis. This is comes with the persistent low-grade intraocular inflammation with posterior synechiae, usually young girls. Herpetic uveitis, this is also I am getting from the uvea specialist. But here is very interesting, the acute rise of intraocular pressure with active idiopsyclitis, and the cause is herpes simplex, herpes zoster, and varicella zoster. And very interesting finding, the UVA specialist, you know that there is some sectoral iris atrophy. In such cases, this is also a very important diagnostic sign, fibrin deposition. Sarcoidosis, I'm getting some referral cases from the UVA specialist, and the secondary glaucoma is not very much uncommon. The pathogenesis is actually the swelling of the trabecular meshwork, mechanical obstruction, peripheral anterosynechiae, posterior synechiae, and neovascular glaucoma. I'm also getting some cases of syphilis. It causes the secondary open angle glaucoma and later on the neovascular open angle and neovascular angle closure glaucoma. And in that case, usually in the syphilis, the medical treatment fails and filtration surgery with antimetabolites is needed. And sometimes I need to do the drainage tube implantation. So, okay, fine. That is glaucoma has developed and secondary glaucoma, but we should not miss that all cases may not be the glaucoma. Inflammatory ocular hypertension syndrome is one of the cause of raised intraocular pressure here. So here the glaucomatous damage may not occur before sometimes after uvea control, uveitis control, the intraocular pressure is controlled. In that cases, it is called the inflammatory ocular hypertension syndrome. And we have to think about the steroid-induced glaucoma also can be associated, may not be, it is associated with the uveitis. It may be a case of steroid-induced glaucoma. You have to take care of that also. So if you discontinue the medication and taper the medication, the intraocular pressure can be controlled later on. So what is the principle of management of uveitic glaucoma? The two principles. One is we have to manage the uveitis, we have to manage the systemic cause, and then we have to manage the glaucoma. So challenges of treating the uveitic glaucoma, it's my personal experience. We cannot use the pilocarpine here. What are the challenges actually? We cannot use the pilocarpine here because it causes the spasm and it aggravates the inflammation. And also prostaglandin, as it is a prostaglandin, it's self-inflammatory mediator, so it induces the inflammation. So two anti-glaucoma medication we cannot use. And also fibrinous membrane formation. If the fibrinous membrane formation, so you cannot, so trabecular mesh outflow is hampered. So this is also a challenge. And trabeculectomy surgery, we have to wait for the inflammation should be reduced, because if the inflammation is not reduced perfectly, if you do the trabeculectomy, the post-operative inflammation will be more, and this will aggravate the condition, and ultimately the aim will not be fulfilled. So management. So beta blocker is a good choice if until otherwise contraindicated, and then carbonic anhydrase inhibitor I used to, and systemic carbonic anhydrase inhibitor with a very minimum period as the intraocular pressure is raised. Even hyperosmotic agent has a great role because sometimes it comes with a very high intraocular pressure. So this is different studies suggested that Rho kinase inhibitor have a great role treating the uveitic glaucoma. It is not available in Bangladesh. I don't know where it is available in India or not, or Singapore. It is a question to everybody. I don't have any experience to using this Rho kinase inhibitor. but it has a great role in, because it works in a different way. It increases the blood flow to the optic disc, protecting health of the ganglion cells, antifibrotic agent, post-glaucoma surgery. These drugs are in the pipeline, but still, I think US FDA has been approved the rho kinase inhibitor in the USA. Okay. Then the surgical management. You know, the uveitic glaucoma is a very refractory glaucoma. So sometimes surgical management, almost 50% cases needs the surgical management after reduction of the inflammation. So trabeculoplasty, laser iotomy, I've already told, trabeculectomy, non-penetrating glaucoma surgery, drainage device, and cycloablation. Trabeculoplasty actually, different studies suggested it has a little role, but in my experience, it doesn't really has a very good role. Laser iotomy, obviously, in the angle closer glaucoma, it has a great role. And I used to prefer the multiple laser iotomy in the in case of Irish Bombay cases. But my experience that if it is not uveitis is not controlled, even after after 2 or 3 weeks, I have if the uveitis is not controlled, this iotomy is closed, and then again we have to do the laser iotomy again and again. Trabeculectomy. It has a great role if it is inflammation is controlled with the maximal medication. If it doesn't work, I used to do the trabeculectomy, and with mitomycin C. I don't have any experience of using the 5-FU because mitomycin C 0.04% works good. And this is the study in the uveitic glaucoma, the intraocular pressure control within the first year is 90%, and the second year is 79%. Different study. Most of the study shows that the good result is more than 70%. If it is, we use the mitomycin C or 5-fluorouracil as an adjunct. Drainage device. I have some experience using the drainage devices in case of failed trabeculectomy, and also in case of childhood uveitis, where the in also some pseudophakic uveitis. I prefer to use the armored glaucoma valve implantation FP7. And usually different studies suggested that the armored glaucoma valve has a good result in case of uveitic glaucoma. Almost 80% success rate in the first year, almost 50 to 60% in the second year. And non-penetrating glaucoma surgery, where the mechanical obstruction of the trabecular meshwork, usually the viscocanalostomy works better. But I don't have any experience on the non-penetrating glaucoma surgery, and I don't like to even do that. Cycloablation. If it is a almost blinding eye and painful blind eye, in that case, cycloablation have a great role. And some studies suggested that endocyclophotocoagulation in a case of uveitic glaucoma, it is not very much inflammation associated, but the intraocular pressure is rising. In that case, then endocyclophotocoagulation works better, but I don't have any experience about that. So future delivery, there will be some future delivery system like the fluocinolone acetonide implant, but they have a greater risk of raised intraocular pressure. Implantable devices. This is one of my case where the bilateral and uveitis, I did the peripheral iotomy, and still an intraocular pressure was raised. I did the combined operation in the both eye, but the right eye, the inflammation was more. So the postoperative picture, even though the 6-9 intraocular pressure postoperative picture is like that, but intraocular pressure is still higher. And I did the Ahmed glaucoma valve implantation in that cases. This is the video of that case, Ahmed glaucoma valve implantation. So I'm doing the conjunctival peritomy here, and I'm making the space for the valve implantation. The most important thing is we have to take care of special things, as it is a case of old uveitis, so it may be associated with the scleritis or any other thing. So we have to take care of the sclera, conjunctival incision and everything. Here the priming has been done to see the valve patency. Now the Ahmed valve is fixed to the sclera. In that cases, we have to take care of that sclera should not be perforated, as it is a case of inflamed eye already. So in that case, we have to take care of the sclera also. Now I'm cutting the tube. We have to take care of that the tube should not be too large or too small, because this tube can touch the iris, and that may aggravate the inflammation, and that will be a blunder for the patient. The tube is inserted in the anterior chamber. Now tube is going to be fixed with the sclera. So here the tutoplast, the patch graft is very much important. Sometimes we can use the dried sclera, we can use the dried cornea, but tutoplast, I think I prefer to use the tutoplast. It's really very patient friendly, and I'm just covering the tube with the tutoplast. And the tutoplast is going to be fixed to the sclera. And again, you have to take care of the sclera, that the sclera should be perforated, because it induces the inflammation, and it may cause the choroiditis and cyclitis postoperatively. We have to take care of that. Now peritoneum is going to be closed over the tutoplast. And we are done with a very good post blave, and the tube is in the anterior chamber. It's a pseudophakic eye, and postoperatively it looks better. This is the ultimate preoperatively. It was almost 54 millimeter of mercury, and now it is 12 millimeter mercury. So we have to keep in mind intraocular pressure check in uveitic cases. We should take care of the systemic association. Choice of anti-glaucoma is very much important. Be careful about the white uveitis. Time of surgery is very much important, which I've already discussed. We have to use the anti-metabolized using the glaucoma surgery. Choice of surgery is also very important, and we have to take care of the steroid-induced glaucoma, which might be associated with the uveitic glaucoma. Thank you. This is our institution, Chittagong Eye Infirmary and Training Complex, and we are welcome to the Chittagong and our institution. Thank you, everybody. Thank you all firefighters.
Thank you, Dr. Numan, for your very interactive and nice presentation. I'd like to invite Dr. Niaz Abdur Rahman to talk about something about this presentation.
Thank you, Dr. Rajiv. Glaucoma and uveitis is, when there is an increase in intraocular pressure, it becomes sometimes very, very difficult to control these cases. When the inflammation is there, as Anuman was saying, if there is an iris Bombay, we tend to do you add PI, but it soon closes. And I've had cases that we've done multiple PIs and they keep closing. We've even gone in and did a surgical PI, but still that closed down. So it's very important to control the inflammation and to find out the underlying cause, or else the PIs, they just close. And what I think is that in these cases, you shouldn't wait too long before you take a decisive action. If you have to go in for a surgery, you have to, give lots of steroids and somehow control the inflammation a bit and then do your glaucoma surgery, or else the patient has permanent visual loss. It's not always easy to handle these cases, and if you delay, the eyes go bad and then they become blind eyes or they become physical. That's what I've found in many cases. I have one thing that Roma didn't mention is I have seen cases where the uveitis was induced by the IOL, that is a wrong IOL. For example, if there was a PC rent and in the bag IOL was placed in the sulcus, then that can cause a uveitic reaction. And I have seen two the ends of the spectrum. One is low-grade uveitis where the patient has good vision, but he suffers from a low-grade inflammation throughout his life. You know, that is an irritable eye, that's a painful eye. I mean, discomfort is always there. That's one end. The other end is I have two patients who have eventually lost their eyes because of very fulminant uveitis when their PC IOL, which was supposed to be in the bag, was placed in the sulcus. And they developed severe uveitis, and the surgeon didn't realize what was going on, kept on treating him with steroids and doing multiple PIs. Eventually, when we saw, the eyes became soft and you know, we lost the eyes. So that is one thing we should remember when we're doing cataract surgery. If there's a PC rent, we should give a 3-piece lens or a lens which has got angulated haptics, not 0-degree lenses that would prevent the uveitis. So that's about it, but always treating eye with uveitis and glaucoma, it is always a challenge. Noman, thank you very much for a wonderful presentation. You've shown the whole spectrum of the diseases that can cause the glaucoma and all the things that you can do. But you know, if you can control them medically, that's the best, without going into surgery, because surgery itself has risks, and the glaucoma valves that you can give, eventually they can also clog down and they don't stay patent for very long. Thank you.
So
thank you, Dr. Nias. Yes.
I have one question to Dr. Partho. What is your experience about the secondary glaucoma and their presentations in your clinic? What type of uveitis you have experienced secondary glaucoma? What type of uveitis?
Yeah. So glaucoma and uveitis, I think it's goes hand in hand. So it can be due to steroid response. It can be due to the inflammatory, as you have already discussed, the entire spectrum. So any case can develop the ocular hypertension. So you have to monitor this patients, any patients of uveitis for IOP checkup, and all patients you have to do a gonioscopy, thorough examination, and every visit you should perform IOP and examine the disc properly.
Thank you.
Dr. Shah sir wants to talk about something. He wants to tell something.
Yeah. I think when to do surgery, there are very few cases of uveitis with glaucoma where in active stage you can still do surgery. And I think that should be added up in very good presentation of Dr. Noman. One is lens-induced uveitis superadded by glaucoma, phacoanaphylactic, phacolytic glaucoma. So it is very important to identify these cases and do surgery, cataract surgery, when the uveitis is active, even when there is fulminant, because that is the real treatment for that uveitis in glaucoma. So that part, we should never forget that there are some cases of active uveitis where still surgical intervention is possible and yields very good result. One more thing, it was talked about that in long-standing chronic uveitis and where steroid does aggravate the intraocular pressure. One of the experiences that I have, and I have done that in several cases with very quite satisfactory outcome. Not in every cases, but in majority of the cases. We have to strike a balance between minimal inflammation and steroid-induced hypertension, ocular hypertension. What I have done in some of the cases, control the active inflammation to the minimal extent, and then where one daily dose, one drop of a steroid is able to keep the inflammation almost under control or minimally active, yet the intraocular pressure is raised, then we can switch over to alternate day single dose of a steroid. And it is quite rewarding that alternate day steroid does have minimal negative effect on the intraocular pressure. At the same time, it is able to keep the inflammation either under control or at the minimally active level. And if we are able to manage the inflammation control totally and have a duration of at least 6 to 12 weeks, we can always go for surgical intervention. And one thing I would like to restrain very much is that any laser iridotomy, it doesn't take even few days. Sometimes you do today morning, by evening, if the inflammation is very active, you will see that it is closed. And in couple of days, almost every case of laser iridotomy in active uveitis will have iridotomy closure. So we have to depend on something else, maximally medical therapy and appropriate occasion, surgical therapy. But laser iridotomy, I have shared this and got the experience of several other workers who all agree that is something that we should avoid in active inflammatory cases with angle closure component, because it also increases inflammation to a tremendous degree. Laser iridotomy is not a very safe procedure as far as inflammation is concerned. In majority of the cases where inflammation is active, it leads to more and sometimes very severe inflammation. So we should refrain that.
Thank you, sir, for your nice addition. Now I'd like to invite Dr. Vishali for her some opinion, expert opinion regarding the issue.
No, I guess everything has been said already. Only point I would like to say is uveitis normally presents with the low pressure. So if you are seeing active uveitis with a high pressure and no history of steroid exposure, always rule out viral anterior uveitis, because that's the only form of uveitis where you will have high pressure and uveitis. So Partho's already told you the features of diffuse keratic precipitate, iris transillumination, but that glaucoma is caused because of the inflammation and is going to respond to steroids and maybe antiviral if it is CMV, and not mainly to anti-glaucoma. So you have to be like what we used to call glaucoma cyclitic crisis. These days is mostly CMV anterior uveitis that will respond to Wirsson gel and anti-glaucoma. So that is one important indicator.
Thank you.
Thank you. Professor Don, do you want to add something?
Professor Don Lim?
Hi.
I think it's very late.
So in my practice, actually, I usually wouldn't recommend surgical iridotomy if really required and if medically unable to break the secondary acute angle closure attacks, I would actually recommend a surgical iridectomy. And I see that these cases, though few, they do well. So this is one of the points I'd like to raise. And secondarily, in my approach to hypertensive uveitis, like what Dr. Vishali correctly pointed out, actually I I offer an aqueous tap to all my patients to present with diffuse KPs, the PSS FHI-like picture. So typically we would send out the aqueous taps for viral tetraplex, looking for hepatic viruses, VZV and CNV. So it's quite a proportion that we detect here. I'm not too sure about the epidemiology of this hypertensive uveitis in Bangladesh, but at least in Singapore, we do see a sizable population with CNV anterior uveitis and HSV uveitis. So just these two posts I'd like to share with everyone.
Thank you. Dr. Partho, you want to add something?
No, nothing to be added.
Okay.
From my side.
Okay, thank you.
Professor
Professor
Hussain is there?
Professor Hussain, you want to add something?
Professor Hussain, what is the comment on this last comment about this webinar? Are you here, Dr. Hussain?
No.
I think Dr.
Yes,
Rajiv. Yes.
Yes, I am here. Yeah. So everything I think have been covered and very good webinar, and all the panelists are extreme experts in their field. Can I have one question? So if we have a time for a few seconds, can I have?
Yes. You can.
My question is basically how many of us usually take retinal biopsy when they are unable to diagnose posterior uveitis, and if someone has experience about retinal biopsy for diagnosis, so how many times you get your desired results regarding the diagnosis? So can I have any opinion?
Very rarely, actually it's not only the retinal, it's retinochoroidal biopsy. And more than doing the biopsy, you need a very expert person in the laboratory who can give you the diagnosis from that little bit of sample, because by and large that sample gets lost by a routine pathologist. Now, what are the conditions where you would like to do? Most of the times when you are suspecting lymphoma, and it is very important to know that lymphoma is actually subretinal and overlying retina may be normal. So if at all you are doing it for lymphoma these days with 27G, I'm basically a retina surgeon. So you make a small retinotomy, put your soft tip extrusion, and I do it under intraoperative OCT guidance. You aspirate the subretinal deposits. You really do not have to do retinal biopsy for that. Very rarely you may have to do choroidal biopsy if you're thinking of something exotic which you are not able to get, which is technically doing the biopsy is not difficult. By I guess you need person like Dr. Biswas backing you up to actually get the diagnosis from the biopsy, and that is extremely important.
Okay, thank you. Yes, sir.
Dr. Rajiv,
yes, sir.
I would fully support Dr. Visali about the retinal biopsy, or as said by her, it is always chorioretinal biopsy. First was done by Dr. Daniel Martin and Mark D. Smith at National Eye Institute in early 90s. And very frequently it is done when both eyes are involved, where vision is extremely poor in the eye, where surgeon is planning to do chorioretinal biopsy. And a couple of cases that they did, Dr. Martin and Mark Desmet, mostly they were the cases where retinal fibrosis, chorioretinal fibrosis had already occurred. But to salvage the other eye, they did the biopsy. So it is after a lot of thinking as far as how it is going to benefit the patient, one should contemplate the chorioretinal biopsy. Yes, in selected cases, it has been found to be beneficial for the patients. And especially as I was telling, where both eyes are involved, one eye has virtually lost the vision, the other eye is at the risk. To establish the diagnosis and plan the treatment, one can ponder about doing chorioretinal biopsy.
Thank you. I think you can,
We're at the end of the session almost. Thank you for all these things. I like to invite Professor Sharfuddin sir to deliver the chief guest speech and conclude the session as a president of the OSB.
Oh, thank you very much, Dr. Rajiv.
Yes,
I'm very much honored to be the chief guest of this excellent webinar, the international webinar of 6 countries, Bangladesh, India, Pakistan, Nepal, Indonesia, Singapore, and all the legion on uveitis. They have talked today, and I think all the speakers and all the panelists, they have discussed so nicely that this webinar is an excellent one to all the ophthalmologists who are attending with us, and Bishali was also with us. He has given a lot of input on uveitis, and you see Parthopati Majumdar, he has given 10 points, and I think if the residents remember only 3 points: don't treat uveitis without examination of the fundus, non-dilated people should be examined in the slit lamp, and another one, the operation should not be in the inflamed eye, but except which one? Phacoanaphylactic glaucoma. In this case, you can also operate. And you see, all the Ronju has mentioned one thing which is not known to us. Probably we have missed it. And this type of seasonal hyperacute uveitis, TAPU, we should also try to find it out. And you see, the Professor Bishali, Professor Hossain, Professor Parthopati Majumdar, Dr. Jahidur Rahman, Dr. Ronju, Don Lim, and Dr. Reena, I think they have given their input in such a way that this webinar has risen in such high up like Himalaya. And I think Dr. Noman and Dr. Rajiv and also Masood Parvez from OSB Chittagong, they have organized this in such a way that I, as a president of Ophthalmological Society Bangladesh, I thank them, and I hope in future other international webinars will be also organized by Chittagong OSB and also Central OSB, also Bangladesh Ophthalmic Research Forum, and also other societies, subspecialties of Bangladesh. I thank all of you, and I think in future we will see you again face to face after COVID. I hope you all will be healthy and a healthy long life. I wish you a healthy long life. Thank you very much for joining with us. Thanks a lot.
Masood?
Can you, Masood Bhai is not here, I think. Can you please, we can take a combined photography, please, with a thumbs up, please. Everybody, a thumbs up sign. It will be a great memory for us. We'll take a photograph. Ready? 1, 2, 3. Ready? 1, 2, 3. Thank you. Thank you.
Thank you so much, Dr. Numan. Thank you.
Dr. Masood Parvez has come. Dr. Masood Parvez, do you want to tell something? Hello, Dr. Masood Parvez?
Unmute yourself. Unmute yourself.
Dr. Masood?
Thank you.
Thank you, everybody. I think.
Thank you.
Thank you. Yeah. Bye.
Okay.
Thank you. Good night.
Good night.
Good night.
Thank you very much.
Good night.
Thanks to
Good
all.
night. Thank you everybody for joining
Thank
us.
you.
Thank you so
Okay.
much.
Thank you. Thank you. Thank you.
Thank you. Thank
Thank
you.
you,
Thank
Professor
you, sir.
Hussain. Thank you, Ranju.
Yes.
Thank you, Dr. Reena.
Okay. Thank you very much. Jahidur Rahman Pannu,
Thank you,
Runju.
Pannu bhai.
Yeah.
Thank you,
Reena.
Ranju.
Thank you, Dr.
And
Dom.
Professor Dr. Dev Naran Shah. We will see you again in Nepal.
It will be a pleasure.
Yeah, thank
Yes,
you.
sir.
Thank you.
Okay. Thank you very much.
Thank you.
Thank you.
Thank you very
Thank
much.
you.
Sign out করে দেন।